Okay, normal chest x-ray. You know what that looks like. Okay. We got the different positions. We have posterior, anterior, from the back, forward. Posterior, anterior. Then you have anterior, posterior. Then you have lateral. Then lateral decubitus is laying on the side. Whereas just lateral is you can be sitting up or whatever. Obliques are just this. Forced expiratory images. Now, that's not on the test, but I guarantee that'll be on the final. A child aspirates some peanut or a Lego. You take a chest x-ray normally, it is not going to show up. Because they don't have radio-opaque lines on Legos or peanuts. Right? So the only way to verify that is to take a deep breath, exhale quickly. Whichever side it's lodged into, you'll still see some air trapping. Whereas the other sides where it's not obstructed, it'll be clear. Like you'll see like a...
That's that one that's in here.
18. Trying to figure out what page I saw
96.
it on. 96.
The coin.
Where is it?
Should be right here on the bottom. Oh, your page is different than mine.
Oh, okay. Well, yeah, if it's in the old edition, it is... Oh, that is the coin? I saw that somewhere. Mm-hmm. Oh, okay, yeah. Well, see, they took a lateral image, which normally they do. They either take a lateral or AP film, anterior, posterior, from the front, to determine... The main thing with that is the expiratory, the exhalation, because, again, it doesn't have a radio-opaque line. It took me a little bit. I was like, why did they do forced expiratory? Doesn't make sense. And I was like, oh yeah, it doesn't have a radio-opaque line. It's not going to show up on a normal chest x-ray. Okay? And then CT scan. We know what a CT scan is. They put them in the thing. It's the spiral thing. Yeah. They look at cross-sectional images. Now, one thing about that is CT scans, they don't do on babies because the babies can't do the enhanced radiation dose. You don't want to give them extra dosing. I know it had it on here. I don't know about that book. Right. Under the age of 14 years because it does not expose the child to ionizing radiation. However, if the mass is located in the retropharyngeal, whatever, we don't worry about that. Basically, is you don't want to expose them to extra radiation that they don't necessarily need. Okay. You said we know what a normal chest x-ray is, heart, lungs, diaphragm, you know what all that looks like, right? Okay, now, silhouette sign is, what is it?
Like the cell?
No, silhouette sign.
Like a shadow type thing?
Mm-hmm.
Like the outline of...
Mm-hmm. Silhouette sign is where normally on a chest x-ray you have distinct, like you can see the heart line right there. Yep. Now a silhouette sign is where it's blurred. Where it's the distinct
very
line
faint.
Is blurred for some reason, whether it's secretions, inflammation, or whatever cause it can be. Now, in the mediastinum you have the thymus, which has the sail sign. If you want to look in my book, it's because it follows the... Okay.
Yeah,
right? Thymus. It gets, yeah, you see that sail sign? It's like a sailboat. That's the normal sail sign. And then, you know, normal chest x-rays, the darker it is, the more air they've got in there because it doesn't bounce off. Now, the positioning of PICC lines, chest tubes, endotracheal tubes is the gold standard to verify that it's in the right place is a chest x-ray because it has the radio-opaque line. Right? Central venous pressure line, pulmonary artery catheters, all that stuff. Because they all have radio-opaque lines. Now, the airway obstructions, now this was on the test. The croup is also called laryngotracheal bronchitis. That is on the test. She doesn't say croup. She'll say, oh, they have upper airway edema after extubation. What do they have? And she's got laryngotracheal bronchitis and 3 other options. I don't remember what they are. but it's laryngotracheal bronchitis.
I
Croup is laryngotracheal bronchitis.
was gonna see if it said it.
Is that on there?
It doesn't say that. Does yours? Oh, there it is. Is that right?
No, that's
No.
retropharyngeal cellulitis. That's different. No.
Should I just write on my PowerPoint?
Yeah, it's on the PowerPoint.
Or I could do this right here.
Yeah, you can do that. If you want, after we get done, you can take pictures of all this and take it home and, look at it. It's totally fine with me. I don't care. Now, croup also... Oh, that's how she says it. Croup, because it's... Understanding why it's called that. You have your trachea, right? And then you have... Croup is upper airway edema. You have your face up here, right? Upper airway edema. You got that. You got that. Now, when you take a chest x-ray, right? Church steeples look like that.
Mm-hmm.
Right? So she said he's got a steeple sign on his chest x-ray and he's got some inflammation. What does he have?
So the croup.
Croup. But she doesn't say croup. She says laryngotracheal bronchitis.
Okay.
Right? And then another question is a thumb sign. Let me just write this. Croup. Right? And then another one she has. Now I'm going to look at it from a lateral point, like from the side view. You got the person's nose and the face, and then you got the trachea. Now, you got the trachea here, right? And then you got the epiglottis, which comes up, and it's, when they need to breathe in, it comes up, moves out of the way, and then when you swallow, it closes. Now, when epiglottitis, itis is the inflammation of the epiglottis. It's swollen. You know how fat your thumb is?
Uh-huh.
It just swells up. So it looks like a thumb. That's why they call it a thumb sign on a chest x-ray. Yeah, the chest x-ray. Now that is mostly caused by which bacteria? Oh, no, that's not it. My bad. Croup, epiglottitis, hemophilus influenzae. Okay, she doesn't ask what bacteria it's caused by. I think that's a different thing. Okay, and then you have retropharyngeal cellulitis versus the abscess. She doesn't ask anything about that, but it could be on the final, so I don't really know. Retropharyngeal cellulitis versus an abscess. Now, a CT scan is the only way to determine the difference between, is it a retropharyngeal cellulitis or an abscess. Large sinus steeple, large epiglottitis, trachea, retropharyngeal abscess. I don't really know where it's at.
Yeah, I was supposed to say
like.
This picture. I don't know either.
Yeah, it's the same picture. I don't know what it is, so I got the same picture. We'll worry about that later. I'll add that to my thing. Okay. Now, right, that's all.
It says enlargement of the cervical lymph nodes. On my book it says.
I have no idea. I don't even see that crap. But anyways, okay, moving on. You have respiratory distress in the newborn. Now, I don't know if your book, your book has it, CHAMPS,
yeah.
Right? So you got to know what that is, CHAMPS. Congenital heart disease, right? That's what it is.
Like a diaphragmatic hernia?
Congenital abnormalities. No, that would be more in the, not hyaline membrane disease. Don't erase it. Don't leave whatever notes you have.
When she said it there.
Okay, that's fine then. Yeah, that's all good.
And she put cystic malformation.
Yeah, that's fine. Oh, okay, there's a comma there. I thought it was a dash. Yeah, that's fine. Congenital abnormalities. So yeah, the cysts, they would show up as circular little discs.
Little disc things. Okay.
Yeah, like this. You see it? See the little discs?
Mm-hmm.
Through which causes the mediastinum through massive pulmonary interstitial emphysema. No?
Let's see.
There was one that
I remember
showed
seeing
it.
it.
It's not that far. But yeah, it was, you know what you're looking for. You know what it's called. It's like little, that's also on the test. Diaphragmatic hernia. She'll say little round cyst like into the mediastinal area. Okay. And then you have, you know what respiratory distress shows up as on the chest x-ray, right?
Say that again.
Respiratory distress. What does that show up like on the chest x-ray?
Like the ground glass.
There you go, yeah. See, most of this you know is just you get stressed. I know you can do it. You can do it, homie. I believe in you.
Okay. Well, knowing I'm timed is one of the things that gets me.
Don't let that get to you. You'll be faring through and you'll talk around, oh, I still got 20 minutes. Take time. Don't worry about the time. Okay, meconium aspiration. You know, we've discussed that a lot in the previous. What would you see? Not on a chest x-ray. Visual examination, what would you see? It's not on the test, but I'm just making sure you know it.
Visual as far as with a person, if they have it?
Yeah, like you look with the scope, what would you see there?
Like pussy.
Green tinged vocal cords. Because the doctor calls you, well, you know, you're on the delivery team and they suspect meconium aspiration and they don't stimulate the baby yet. So you go in and look and you would see the green tinged or brown tinged vocal cords. That is a clear indication of meconium aspiration. You suction them out and then you stimulate the baby. Otherwise, if you stimulate the baby, whatever they aspirated goes down further and it just complicates their, it just gets complicating quick.
Because it's from the fecal stuff coming up, right?
Exactly. Yep.
Okay.
And you know that when the mom delivers, there'll be green all over. The placenta will be a yucky, nasty color, smell, and much poop. You know. And then, yeah, you got the congenital diaphragmatic hernia. You know what that shows up like. It's where the intestines go up through the hernia. Not the hernia. Well, yeah, the hernia through the diaphragm, and it shows up as little circular discs. Okay, and then atelectasis, we know what that is. Now, when you have atelectasis, does it push it away or pull it closer to the affected area?
Atelectasis is towards
the affected area, like
area.
Pulls it towards, right?
Yeah.
There you go, good job. And then with a pleural effusion or pneumothorax,
it goes away.
You got it, home. There you go. And then pneumonia, we know what that is. You know what it shows up like on the chest x-ray. Patchy white areas. Yeah. Pulmonary abscess. A pneumatocele, that's what it is. A pneumatocele is pneumonia. Pneumatoceles. Thin-walled, air-filled cavities in the lungs. Not alveoli, just thin-walled, air-filled cavities caused by Staphylococcus bacteria. It's not on the test. Half this shit's not on the test. Excuse my language.
That's what a lot of people said. No.
I'm trying to go over it, but I'm trying to highlight what's on the test also. Pneumatocele is caused by what bacteria?
The Staphylococcus.
Staphylococcus. You got it. Staph. MRSA. Okay. Asthma. We'll cover more in depth of that later, but the gist of it is a reversible airway disease, right?
Reversible asthma.
Reversible, yeah.
Yes.
Reversible compared to COPD, which is not reversible. It just gets worse and worse and worse. It's just managing it. You have hyperresponsiveness of the airways. Oh, that's yours. Oh, okay. You got tons of secretions. You got atelectasis, pneumomediastinum, air in the mediastinal area. Right?
Yes.
They got x-rays. Now, asthma, they have increased work of breathing. They got recurrent bronchospasms because, they're breathing all kinds of weird. And then chest x-rays to rule out pneumonia. Right. Okay. Moving on to cystic fibrosis. Can I see this? I just want to make sure I cover everything. Pneumonia on chest x-rays. Cystic fibrosis.
Okay. What did you say about the pneumomediastinum?
Is the air in the mediastinal area, like right here.
Okay.
Just think about it. Pneumo means air.
Right, and
Mediastinum.
in here. Okay.
Pneumo, thorax. Thorax is chest. Okay. Air in the chest. Now, cystic fibrosis, the differentiating factor between cystic fibrosis and asthma on a chest x-ray is bronchiectasis. That's one of the questions in the back of the chapter. I don't know if yours has the exact same one, but we will go through that. I see there's the pneumatoceal. That's it. See, which of the following is a hallmark of CF and is not seen with asthma? Bronchiectasis.
Okay.
All the other ones, hyperinflation, they got air trapping because they can't get it out because it's inflammation. Atelectasis, that's pretty much all of them. It is an airway disease. Both are airway diseases. So bronchiectasis is... I had to take a second. I was like, she's going here, Lord.
My eraser.
50% of CF patients have bronchiectasis. I don't know where I got that. She probably said it, but it's not on the test, so that's just a random fact I'm throwing out there. Okay, that's good. We don't have to worry about that. Acute respiratory distress syndrome. You already know that's CHAMPS, pretty much.
Yep.
But acute is in the adult, and RDS is in the neonate. Right? You got near drowning, inhalation, injury, aspiration, all that random stuff. Pneumothorax, pneumomediastinum, right? And then chest trauma, you definitely know what that looks like. You got broken ribs, all kinds of stuff.
Yeah.
Everything just looks horrible.
Yeah.
Yeah, see, enlargement of cardiac silhouette, trauma, widening of superior mediastinum, hemorrhage. That means they got a lot of blood in the mediastinal area. It just widens because there's a lot of blood there. But again, that goes back to
on the
chest traumas,
the
chest X-rays.
CTs and X-rays.
Yes, yes. Okay, now we are going to. I'm not going to let you look at these. Look at these because I don't circle answers.
So let me make sure. You're talking about the blood as far as on the chest trauma?
Yeah, from chest trauma. From chest trauma, they can just come in with broken ribs. They don't necessarily have to have bleeding. Okay. But if they have bleeding and you see that the heart is like, on a normal chest x-ray, it's like this. But if it's like a lot, you know there's something immediately wrong. They've had some kind of trauma or a lot of fluid in that area. Okay. Where's the first one? Mother states that she found her 18-month-old child choking near an open can of peanuts, which set, I can't even read backwards.
Her chest radiographs would most likely suggest airway obstruction.
Okay.
This is the one where we talked about the exhaling.
There you go.
It would have to be frontal inspiratory and frontal forced expiratory.
There you go. That's the right answer. Good job. See, you didn't have to look at the other answers. You knew what it was.
Well, I was looking at them as you were reading it.
Yeah, okay.
That was
well,
the
there
only
you
one
go.
that said expiratory.
Okay. The normal thymus has a characteristic appearance with which of the following radiographic findings? Displacement of the trachea to the opposite side of the mediastinum. Appearance of a sail, wavy margins.
Okay, so normal thymus would be 1 and 2.
Good job. A pneumothorax is suspected on the left in a child's portable radiograph from the intensive care unit. Which of the following may better image and confirm a suspended pneumothorax?
Okay. I know that we gotta do right side of him because it's on his left. And then let's see what the upright frontal. I'm not sure about the cross table.
Oh, let's see. Okay. Okay. Cross table lateral. I don't even know what that is.
I know, that's why I said I don't think that's part of
Upright
it.
frontal, you said that one, right?
Yes.
And let's see, left side down decubitus. You said right side down decubitus?
Yeah, because if the pneumothorax is on their left,
Okay.
you would want to put them on the right.
Put them on the right because the pneumothorax is on the left.
Right.
Good job.
Okay, so just
it's 1, 2, and 4.
even though I don't know what one is.
Yeah, we don't know what one is.
Okay.
But your reasoning is
when
right.
I was reading, I was trying to find that in the reading.
And so you helped me figure this right side down because I was not understanding that. But
Yeah,
I get
I read
it now
it.
because you're taking. Oh, okay.
Because
You're taking it from the top and you don't want the side down because you won't see it.
Right, that's what it said in the book.
I got it now. See, this is what I wanted. I teach you, you teach me. Does it? That's how we get to it. Subglottic edema causing a church steeple. You don't even have to go any further.
I know, epiglottitis.
There you go.
Kind of in the wording
Yeah, there you go, that too. Before intubation, the chest radiograph of a premature newborn reveals low lung volumes and diffuse ground glass opacification. That's where you stop. What is it?
B.
There you go, see? The initial chest radiograph of a neonate in severe respiratory distress and having a scaphoid abdomen reveals multiple round air-filled structures. Remember that? Multiple round air-filled structures to the left of the chest, displacing the mediastinum to the right. This is most likely caused of what?
The air-filled structure. I'm trying to remember what it's called. Is that the...
Just take it one by one. Adenomalformations. It talked nothing about that, so that's not even in there. That's just throwing you off by using big words. Pulmonary interstitial emphysema. Emphysema doesn't show up like, where'd it go? Round air-filled structures. Right. What about staphylococcal pneumonia? That doesn't show up as round air-filled structures.
So it's the
congenital diaphragmatic hernia, because the intestines,
that's what I was thinking.
They're round air-filled structures. They herniate through the diaphragm and they show up right here. Okay. And they push everything away from it. Left lower lobe collapse is associated with which of the following radiographic findings?
Okay.
That one, we don't know what spine sign is, but it's in there.
Okay, so loss of the left side of the heart border. Let me read it again. Okay, so yeah, so that'll be one of them.
Are you sure? Think about it. Loss of left side heart border, left side, and it says lower left lobe collapse. That means it would show up white, right? Because there's no air. Air shows up dark, so there's no air, but you'd still have because it's not a heart problem, you'd still see the heart contour.
Okay, and it's lower. It's in the lower lobe. So
exactly.
Yeah. Okay,
if it was in the lingular area, then you'd see. Yeah. Then one would be one. Loss of the left hemidiaphragm border. That's definitely that's the main sign. Increased retrocardiac density. That means it shows up whiter. Okay. Density is white.
So what does retrocardiac mean?
Behind the heart. Or below the heart.
I was going to say, could it be below?
Below
okay,
the
that
heart.
makes more sense to me. Okay.
Back, below, behind.
So would it be, it would actually be 2, 3, and 4.
You got it. Pneumatoceles. That automatically clicks. Oh yeah, that's caused by staph. Then you read, it could ask you, okay, are caused by staph. What does it show up as? It could ask you that. Or it could ask you as it's asking, staphylococcal, so we know what that is.
Okay.
Which of the following is a hallmark of CF and is not, we know that. We went through that, bronchiectasis.
Okay.
CT scans of the chest in a pediatric trauma patient are not routinely obtained because of what?
The A?
Yep, there you go. Good job. Okay, let's see. Blood gas, chapter 8. Or I don't know what chapter it is.
Yeah, mine's 10. Let me see what that's probably my husband.
Yeah, go for it. Okay, now we're on chapter 8, blood gases, or in the other edition is chapter 10, blood gases. Indications for a blood gas. Do you remember them from adults?
For the oxygenation and ventilation.
Right.
Lord, my mind's blank. Let's see.
Stay calm, it's okay.
Oxygenation, ventilation.
Just think about why you are doing it in the hospital. The doctor wants to know how they are responding to therapy, right?
Yes.
Hey, we put them on BiPAP. How are they doing on it? Get an ABG after 45 minutes on an ABG. Yeah. Or you took them off. Find out what it's doing. Response to therapy. What else did you say? Yeah, it's right there. Evaluate oxygenation, the pH, O2, pH, ventilation. Right? Those 3 things. The hemoglobin, dyshemoglobin, and all that. The shunting, response to therapy, O2, mechanical vent, all that we mentioned. To assist in diagnosis, to help, to see what the problem is, whether it's respiratory or etc., anything else. To monitor the severity of progress, pretty much the same as response to therapy. It goes hand in hand. If they're doing good, it's a response. If they're doing bad, it's that one. Okay, so we know that it's the same. Now, one more thing. The procedure is also the same. Remember the angle? What is it?
At the 45-degree angle.
Okay, now is it with the blood flow? Like, do I do it this way and the blood is flowing this way? Or do I do it this way and the blood is... Do I go against the blood flow or with the blood flow?
Against.
That's a question. The answer is do nothing. I don't know if she'll give you the exact same, but she'll get you confused by saying, oh, it's basically you walk into a room, he's doing an ABG on a neonate, he's got the 45-degree angle against the blood flow. What should you do? Continue monitoring, tell him to switch to with the blood flow. The other option is switch to 60%, not 60 degrees.
Let's just say 60 degrees.
60 degrees. And there was a last option, not it. Just remember, if you remember the procedure, it's the same as the adult. A lot of us got confused and put 60 because we're like, oh, okay, it's a neonate, whatever.
Right.
So just remember, against the blood flow, or else it's not going to go into this range. Right? 45-degree angle. Just remember that. You're golden. Now, pain control. If the child is more than 4 months, what would you use?
More than 4 months?
Greater than 4 months of age.
Like...
To control pain.
Like lidocaine?
You got it. And if they're younger than 4 months?
I don't remember this one. I don't remember this one.
Put sucrose on the nipple and just give to them, and
that's right,
they're
to
good.
soothe them. Okay.
There you go, to get their mind off of it. Okay. Now, you know, the same procedure, like the modified Allen's test, you do all that. Now, the sites, it's not a little bit different, but there's some places you avoid or keep as an extreme last resort.
Yeah, I was reading in the book.
Go ahead.
And it says the preferred is the radial.
Radial, right?
And I heard someone say brachial, so I was confused.
No,
I was like, that makes no sense.
No. Okay. For the neonate.
Because we're doing...
This is Ms. Bratton. You also got to think. Trick questions. It says radial. She wants umbilical.
Right.
Remember that stupid crap?
Yeah. The UAC.
This is how it goes. Umbilical, radial, and then capillary, right? And then...
The heel?
Yeah, the heel stick is the capillary. Yeah. Yeah, the heel stick is the capillary. Femoral, yeah, same capillary. Okay. I just call it that because you could do it different places. Okay. The femoral and the brachial, extreme last resort. And that also, I don't know if it says in your book, but in my book it says...
I just marked it on here. I put a void, if possible.
Yeah, because...
Emergency use
Because it said only done by a trained specialist. Like a surgeon or something like that. That's what it said in mine. That do not do it. Okay, so you know those, right? You are good with those. Arterial puncture, contraindications, same as the adult.
Okay.
You know, they have low perfusion, can't get it, don't do it.
Don't do that.
They're on any kind of anticoagulant therapy, don't do it. Right? Lack of collateral, failed Allen's test. Find another site or don't do it. Extremities previously blanched. Stick. Don't use it. Do something else. Distal to or through surgical shunt. That we'll discuss in a little bit, but just remember, do not go to a shunt. Sign of infection. Give me 2 complications of an ABG. Or capillary blood stick. Sorry. That's a question.
Capillary?
Yes.
Bleeding?
Hemorrhage, yep, there you go.
I think. Just read these last night.
Remember what she said? Did I say complication? I said complications, right? Okay, complication.
Yeah. Trying to think.
Think about it.
Like tissue damage, maybe? No.
Which is called... No, you're right. Which is called...
Hematoma.
There you go. It's the same as the adult.
Okay.
Name some contraindications for a capillary blood stick. That's also on there. Name 2. Contraindication. Reasons why you wouldn't do it.
Okay.
Complication is you done it. Oh, something went wrong.
Like.
Capillary blood stick. Think foot.
Oh, okay.
Remember, she said they start walking.
Okay. The callus.
There you go. One more. You said it first on the complications.
On the bleeding part?
Just 2.
Hemorrhage.
That's all you need to know, 2. There you go.
Okay. It's easier than I'm making it out to be.
Telling you, it's not difficult material. They just, whoosh, here's all of it.
Yeah.
It's not difficult at all. Complications, see? Hematoma. Apply adequate pressure. Laceration of the artery. If you keep sticking it, it's a baby.
Yeah, they're tiny.
If you keep sticking, you will tear the artery. Nerve damage. There's a lot there. You accidentally go around or get in the wrong spot, you hit something, it's a baby. They still got their whole lives to grow. If you mess up that one thing, it could prevent a lot of stuff. You know the indications, common sites, you know, right?
On the...
ABGs.
ABGs. Mm-hmm.
ABG, CBG, whatever. You know, right? Radial. And then?
The umbilical. You're talking about for the baby, right?
Yeah, and you can name them in order, preferred order. Name them in preferred order. Go for it.
Umbilical.
There you go. Good.
Radial.
Good.
And then
Yeah, you're right. You're right. Capillary blood sticks. And then you just have to know capillary blood sticks are
in the heel,
in the foot or
finger.
Little. You got it. See, contraindications and complications of a capillary sample. We just went through that. Name them again. Give me a contraindication for a capillary sample. Just give me one.
Hematoma.
There you go. Give me a complication of a capillary blood sample.
A complication
You've done it. Something went wrong. What went wrong?
Emboli, maybe.
Clot. Yeah.
But bleeding.
Maybe.
The hemorrhage part.
Let's say you did it. They're still bleeding a little bit, but you went ahead, bandage off. You left. You come back. They're spiking a fever. What happened?
The infection.
There you go. You can also put that. Complication. Just apply it to scenarios. Just say, okay, they were bleeding a little bit. I put it on there. Came back. Oh, you peel it off. You see some pus. You're like, oh, it's infected. That's a complication. Got it? Okay, we'll get to that. Alternative to ABGs. Okay, capillary blood samples. They're good for pH and CO2. Do not use a capillary blood sample for O2 monitoring. Don't get a PaO2 from capillary blood sticks.
Okay.
You can monitor pH, CO2. Got it?
Because the capillary is not going to give you the correct reading, right?
Exactly.
Is that where it's kind of false positive?
Yep.
Thing?
Yep. And then capillary PO2 to determine oxygenation is not recommended. We just went through that. Now, if the child, neonate, adult, whatever, this is for all any ABGs, it's less accurate when they're hypovolemic, which makes their blood pressure drop. When they're hypothermic, when they're cold,
freezing.
Yeah.
Normally.
Which makes the, remember the O2 dissociation curve, the loading and unloading of oxygen? It decreases the unloading of oxygen. And hypovolemia goes with hypotension. Decreased blood pressure, they go hand in hand. If you got hypertension...
Hypo is low, hyper is high.
Excessive,
Correct.
Yep. Puncture sites, you know those already. Okay, capillary blood gas samples. You know those earlobes are good. You said this, and then the distal ends of the things. And remember to warm them. What was another question on there? You could also put burning as a complication for a capillary blood stick because you have to heat it. I had totally blanked on that. I'm sure I got it right, but it didn't even click. I would have put that in a heartbeat. That's easy to put. Remember, you got to warm them up for the capillary blood to get the perfusion there.
Yeah.
And if you heat it up too much, they're burnt. Can't use that anymore.
That just helps.
So that is a complication.
The capillary thing.
Yep, there you go. Contraindications. We did that. Neonates less than 24 hours old. Not on the test, but I'm just going over it because it might be on the final. Decreased peripheral blood flow, polycythemia, excessive blood cells, which means it can clot easily. And, you put it in there, emboli, like you said. Edematous, inflamed, infected, calloused. You got that. Complications, burns, infections, scarring, inflammation. You got that. You're down. You got all that. Now, arterial catheter, umbilical artery catheters. I remember this being on the test. There are two arteries, right, on the umbilical artery. They're located at the 5 o'clock, 7 o'clock position. On the clock, 5 and 7. And then you got the vein in the middle. Okay. Now there's two placement positions. There is a high position. What the hell is that? Oh. You got a high position. Okay, you got a baby. That's an arm. A leg. Fuck, I can't draw shit. Excuse my language. I don't know what that is. Whatever. Okay, you got the heart here. Got the aorta coming down. Right, and then it splits off, branches off. Now, and then you got their spine back here. Now there's a high position. High position is all it has. Low position. You're going to do freaking amazing on this test. Okay. High position. It is, you see on the PowerPoint? It says L high.
Oh, okay.
Right? L. Look, L. Was it 3 and 4? L3, L4?
L3, L4.
Yeah.
That's on the
L3.
low, though.
Yeah. Low. LL, low, low.
Okay.
L3 to L4.
And then high.
Now, L, just so you know, I don't know if we have to know this or not, it's just the lumbar
Lumbar numbers.
lumbar vertebrae.
Yeah.
LL, low, low. Now this one, Jimmy gave me a really good idea for this. Top.
Huh? Good.
Top. And that's what, 6? T6
8.
to T8?
Mm-hmm.
That's on the test. Top. Thoracic, 6, wherever that is. That's how far you push it in from the umbilical artery. If you want it in a low position, you push it to the lumbar 3, lumbar 4. If you want it in a high position, you put it to the thoracic 3, 6 or 8, which would be around like right here somewhere. That's good for pushing fluids, what is it? Nutrients, drugs, measuring things. You push anything through there. And then you put it through a transducer. Remember that? That's covered in Mr. Porter's class. Transducer takes a analog signal and turns it to digital. Now we'll get to that. Peripheral artery catheterization. Peripheral artery, that's radial artery cath. Right? I'm trying to think if there was a question on the test. No, I don't think there was. Okay, pediatric patients. Now you see it says percutaneous or cut down. Percutaneous is through the skin. Cut down is where they go around. They pretty much peel back the skin to visualize the artery, and then they just put it in.
Ooh.
So that decreases for a neonate.
Why would they do that?
It decreases having a chance to lacerate it or break it. They can put it in with more precision.
But wouldn't that leave? I mean, that's cutting.
But it's a baby.
It's like, really
they heal
thin.
Quick. Exactly.
Okay, I got
Whereas
you.
if you puncture it and it starts bleeding everywhere, it can damage a lot of other things.
You. Okay.
Or if you're going in blind, you hit a nerve. Again, a lot more complications. Right? Again, see, modified Allen's test, the same thing. And if you can't see it, use a transillumination thing. You put it, shine through, you see it.
They're about translucent anyway.
I know, right? Okay, let me make sure I'm not.
Especially when they're preemie like that.
Mm-hmm. Yeah, you can pretty much see everything. Okay. Arterial catheters, complications. The same, hemorrhage. Ischemia is not having enough blood flow through tissue, which causes it to deaden or start to die. Okay. As ischemia. Air embolism, that's dangerous because if you have air in there, it travels to the heart.
Brain.
Heart.
You mean?
To the brain. Hemorrhage, you know that. Thrombosis. Clotting, that's what that is. Less than 5 years of age. Infection, if it's in there for more than 72 hours. 5. Page 5 on the PowerPoints, top, middle left. Right?
So thrombosis is the clotting?
Yes. Just think about it. Thrombus is a clot. Thrombosis is the formation of a clot.
Okay.
Right? And then you got the umbilical artery catheters, the same thing, hemorrhage, all that says. None of that's on the test. Arterial catheter measurements. Here. They can measure blood pressure and pulse pressure. That's it.
That's it.
Pulse pressure is systolic minus diastolic. The higher number minus the lower number.
Okay.
Yeah? Blood pressure, you know the normal values. You're good there. Another thing, if you don't remember the normal pulse pressure, but you know the normal blood pressure, you can calculate it. It's the higher number minus the lower number. Go ahead.
Okay. I'm trying to remember right. On the blood pressure for neonates, they're a little different, aren't they?
Blood pressure for neonates, that was in our last thing. It was...
I'm trying to remember. My mind is totally blank. What I was thinking it was a little bit different.
It is different. I can't remember.
What was it? I don't even remember. That's bad, isn't it?
That's all good. See, I didn't really study.
Right here.
You get it? You get it?
I think this is it.
What is that?
It's talking about this systolic and the diastolic blood pressure.
Yeah, no, that's it then.
This goes by birth weight.
Just look at 4. Just look at greater than 4. 65/40, is that what it is? I can't really cross.
Yeah,
in my brain.
65/40.
Yeah, 65/40. There you go. I think we used 60/40. If I remember correctly. But
I'm gonna do that.
That's not on the test, you ain't gotta worry about it. You can mark it for our final, whatever else she might want to come up with. Okay, continuous invasive monitoring. They have a machine, remember she said for babies, any blood you take out, get your results, put it back in. They don't have enough to start with anyways. That's where this continuous invasive blood monitoring comes in. It's just a machine on the side. I don't know if your book has a picture of it. It's just a machine on the side. You can, there was no name for it. It was just inline monitoring. It takes the blood, analyzes it, sends it right back. Yeah, if you don't have it right here, it's just a stupid picture. It doesn't even really matter. Small patients, small blood volumes. You can use it in the artery or UAC, whichever one you got open, for that patient. Central venous catheters. You know what that is, right? You know where it sits. For Mr. Porter's class, sits in the superior vena cava or the right atrium. Yeah. Cardiovascular instability, intravascular volume distribution. You could put drugs, fluids, nutritional support in there. CVP monitoring, the central venous pressures, right? 2 to 6 or 0 or.
So it, and this is the CVP catheters is the same for the babies as it is adults on that.
It might be smaller, but it's probably the same.
Okay.
It does the same thing. Yeah, and you got the monitoring sites, the places you can put it in. Are you on the next page now? Central vein, page 6, right? Yeah, you got the lines. You can put a subclavian, internal or external jugular, external jugular. Brachial, saphenous is down here. Umbilical is, again, your main priority. Procedure. I'm trying to think if there's a thing in there. I don't think there is. Okay, we'll get to that in a little bit. Central venous catheters. Again, sepsis. That's infection of the blood. Again, infection. Embolism. Cardiac dysrhythmias, because you're going, if you need a measurement, you push it into the heart. Exactly. Or perforation of the trachea. Since they're newborns, if you push it just a little bit, smidgen to the left or right, your trachea is right there. You could just go out, put a hole in it. Yeah. It measures. We know what it measures because we studied at Mr. Porter's class. Right atrial pressure, which is left ventricular preload.
Preload, yeah. And I studied it by his little square in my numbers.
Yeah.
And then he asked about the catheter deflation and inflation stuff, and I didn't study that as much as I should have.
It's all good. Don't worry about it. It's just one test. Don't take one test seriously. Each test tells you how good you studied or how bad you studied. That's all it is. If you studied good,
I don't know.
you did
With
good.
me,
No, don't
It don't
let
matter
it
if I
get to
study
you.
for
Don't
hours?
let it get to you.
Or if
No.
I study for just a little bit, I still do about the same.
You'll get better. Don't worry. Okay. Pulmonary artery catheterization. Little stupid picture.
Yeah, that's it's another too. Yeah.
Yeah,
These
right
little-
here. Okay. Yeah. No, this is the capnogram. Right? Yeah, capnogram. Yeah. This. She doesn't ask jack squat about that.
Really? I figured she would.
No, there's nothing on that. Okay, pulmonary artery catheterization, that's where you go through the heart to the pulmonary artery before the balloon is inflated. Pulmonary artery is carrying blood from the left ventricle to the lungs.
Where are you at?
Right here.
Oh,
I'm
the
just
continuous
making
part.
sure you know what a pulmonary artery is.
Okay.
Right? It measures left ventricular afterload.
Yeah.
Right?
You're talking about for the
Pulmonary
PAP.
artery, yeah, PAP is left
Yeah.
ventricular afterload. And then when the balloon inflates, it wedges into the artery or capillary or whatever, and it gets the right ventricular preload. With the right ventricle, which is the main pump of the heart, which pumps it through the aorta to get it everywhere. Right? You can also measure cardiac output.
Okay, so it gets right. I thought it.
If you have
It says CVP.
You have
I
your
thought it was-
square. You have your superior vena cava here. Right? Is your right atrium, right ventricle,
And left atrium.
atrium, left ventricle.
I thought it was
Where
in
you
the
have
left
the-
atrium.
The CVP catheter come in. It measures if it's in the right atrium or if it's out here, it's still measuring right ventricular preload. Can't spell preload. Preload. Now I'm just gonna do.
Well,
Maybe that one's here.
I may have got myself confused.
You probably wrote it wrong or something.
Well, I was right on how he wrote it. I think I wrote it on mine. Because I was drawing it. Where did I draw it? Oh, then I left my other pages. Sorry. Where did I draw it? Did I draw it on my paper? I don't remember where I drew it. But I thought that he said that it was the left atrium. I thought the top, the right and the left atrium, I thought he said those would be preloads. And the right and left ventricles would be the afterloads. I'm confused
and
now.
this, it measures preload for this. How, what the pressure of blood is when it's going into the right ventricle. And then from the right ventricle, it goes, the little catheter goes through the mitral valve, and it goes to the pulmonary artery, which leads to the lungs. Right? And then the pulmonary vein comes back to the left atrium. Now, when you have the catheter go, and it's here in the pulmonary artery, before the balloon is inflated, it's measuring what the right ventricle is pushing against. So it's measuring, this is measuring right ventricular afterload. Can't spell load.
He's got me all confused with his then. That's why I screwed all that up on the test.
And then once the balloon is inflated, it wedges into capillary. And that measures left ventricular preload.
See, I had them backwards.
I'll do that, let me see.
See, I put that these two, that it was preloading here
Right.
and then preloaded again here. And then
Oh, okay. Oh, you wrote PCWP here. What is?
that's how he done it on the board.
Oh, okay. Yeah, you got it mixed up.
He did, because I copied what he wrote.
Oh, okay. Yeah, that's
why I screwed all these questions
more
up.
confusing. Right. And then left ventricular afterload is blood pressure.
Got it. Yeah, I was like.
Yeah, that's pretty much the heart you're drawing.
I was thinking, why did I miss all those?
Right.
By looking at his things, I should have missed it.
Right. And then you got the central venous catheter come in, and if it sits in the superior vena cava, I think the pressure is 2 to 6, maybe.
On which one? I'm sorry. On the.
If it's in the superior vena cava, in the SVC.
0 to 6 or 2 to 7.
0 to 6, and then if it's in the right atrium, it's 2 to 7.
In the it's 2 to 7.
6. And then once it goes into the box, I'm not going to write the values. I mean the things again. Right? It's 2 to 7. Right. That's both of these are still right ventricular preload. Put RVP and then put a little legend for like, okay, RVP is right ventricular preload.
And then that's when it goes up to the left atrium.
It goes to the lungs. Through the pulmonary arteries, which is the PA.
So, say this is my lungs here.
Artery. Horrible, right?
So like this, say this is my lungs.
Yep,
It's going to go into the lungs first.
Yep.
It's
The pulmonary artery.
Into the right
pulmonary
side.
Artery.
And to the left side.
You don't have to worry about that, yeah. It goes through the lungs and then it comes back via the pulmonary veins. But you don't have to worry about all that.
But then, when it comes out of the lungs, it goes into the left atrium. Is that right?
Yes.
And then that's when it's going to do
that
an afterload.
Left atrium is left ventricular preload.
Confused.
It's filling pressure.
No, I was talking about once we go into
the catheter, the venous catheter doesn't go through the lungs, and it doesn't go. It as far as it goes is right here.
Well, I was talking about, you're talking about the blood flow though.
Oh yeah. The
It'll
blood
go
flow.
through the lungs.
Yes. It goes through the pulmonary artery, through the lungs, gets oxygenated, and it comes back through the pulmonary veins.
Comes back through.
Comes to the left atrium.
Okay, yeah, that's what I was thinking. Okay.
Now, that entire system, after it leaves the lungs, when you're measuring with the SVC, you're measuring with the cuff inflated. That's the key. Cuff inflated equals the pulmonary capillary wedge pressure, which is the same thing as left ventricular preload. I don't know if this is on her test, but you probably didn't know it from Mr. Porter's test.
Well,
all of this just merges together.
I got
There's
confused by the way, because I just wrote it like he did.
Right. I know you said you had to go at 5:30.
Yeah, it's getting close. I gotta get our boys and get home here.
Yeah, we still have.